We're going to be talking about the pelvic floor. And I'll tell you, this is one of the more harder conversations that I definitely have with my patients.
So we're going to be talking a lot about our pelvic health as men.
This is the Man Up Podcast, a doctor's guide to men's health.
If you've been enjoying listening to our podcast, please hit the subscribe button on YouTube, Spotify, and Apple Podcasts.
My name is Dr. Kevin Chu, and I'm joined as always with my co-host, Dr. Justin Dubin. This week's episode is titled Below the Belt, Talking Pelvic Floor Health, featuring Dr. Susie Gronski. And Justin, we're going to be talking about the pelvic floor, and I'll tell you, this is one of the more harder conversations that I definitely have with my patients. And, but there's just so much important in our realm of, care that we give, right, Justin?
Yeah, I mean, listen, there's constantly newer articles. And Susie will know, there was an article in the Wall Street Journal, I think in the last month, about how all these guys in like private equity and finance all require pelvic floor physical therapy because they're tight they're sitting all day, they're doing all this stuff. But it's an important conversation, and this is a really important podcast, as we were telling Susie before, and we're so lucky to have her join us because it often takes 2 to 3 visits for us to convince someone that they need pelvic floor physical therapy, they need an assessment. But in certain situations, it's a little easier than others. But so we're going to be talking a lot about our pelvic health as men. So I want to introduce Dr. Susie Gronski. She's a licensed doctor of physical therapy, PT. She's board certified pelvic rehabilitation practitioner. She's a certified sexuality counselor and educator, and she's the founder of a multidisciplinary pelvic health clinic in Asheville, North Carolina, which I've been dying to go to. I heard it's awesome. And she specializes in men's.
Fantastic.
You've been, Kevin, you've been?
Yeah, I love it.
I heard it's awesome. Great breweries and everything like that. She specializes in men's pelvic health and sexual health, including chronic pelvic pain, erectile dysfunction, urinary incontinence, post-pelvic cancer rehab. She has a huge social media following. She's wonderful online with a very successful YouTube and Patreon. Welcome, Susie. Thanks for coming on.
Thank you so much for having me. I'm excited to have this conversation with you both.
Awesome. So
all right.
I think, Kevin, you want to start it off?
Yeah, let me start this off, all right? Because I want to ask this question because it's always, the foundation. Because I'll say the term pelvic floor to guys when I'm, in consult with them, and it'll just be like, just deer in headlights, like, what is that? So for guys who've never heard this term before, what exactly is the pelvic floor? What muscles does it include, and why should men care about it?
So I have my model here. For those of you who can see this, it's a male pelvic
Beautiful
model. Yeah, so it kind of shows you all the genital pelvic structure. So let's start with this. So the pelvic floor is a group of muscles that sit at the bottom of the pelvis, so in between your butt bones. And these muscles stretch like a hammock from the pubic bone all the way to the tailbone. And the main muscles that we refer to are the levator ani, which essentially just means to elevate the anus. But you can see here, if we take a look inside that pelvis, we've got muscles stretching from the pubic bone all the way to the tailbone. And those are the muscles that help support the bladder, the prostate, and the rectum. They aid and support sexual function and erection, in addition to the superficial muscles. So speaking of erection and ejaculation, we've got the bulbospongiosus muscle, and then the ischocavernosus muscles, transverse perineal muscles. So all of this grouping, the superficial to the deep pelvic floor structures, all support bladder, bowel, and sexual function. But the pelvic floor doesn't just work in isolation. It's often influenced by your immune system, your cardiovascular system, your nervous system, lifestyle, and your overall health is going to impact the health of the pelvic floor. And that's why pelvic floor dysfunction in men is often multifactorial as well. So we can't just look at muscles and exclude everything else, because your pelvic floor connects to you as a human being as well. And so that's important as far as, mental and emotional factors, which I didn't mention, but I'll mention now. And guys should really know that they have a pelvic floor, but also care about their pelvic floor health because, as I mentioned, these structures are important in bowel, bladder, and sexual function. They aid in core stability and power generation during workouts. They help support the spine, the hips, and the pelvis. And when they're not working well, that can lead to dysfunction such as urinary leakage or fecal incontinence, pelvic pain, erectile issues, or ejaculatory issues as well.
Damn, it does everything.
Everything.
It is literally everything that a man cares about is involved with their pelvic floor. And yet, when we talk about pelvic floor, men don't want to hear about it. So that is such an enlightening aspect of our men's health. And I think that we'll get more into pelvic floor physical therapy, but this idea of pelvic floor therapy, I think, is very, stigmatized in the men's health space, because we often think about women and we think about, oh, they just had a baby, they're having urinary issues, they can go for pelvic floor dysfunction. But like most men are like, why would I ever need pelvic floor physical therapy? So why do you feel that this idea behind pelvic floor physical therapy, pelvic floor therapy is so stigmatized, and there's such a big misconception in the men's health space?
Yeah, I'm so glad that we're having this conversation because you're right. Pelvic floor therapy is often mistaken as just a woman's health issue. But as we just discussed, men have pelvic floors too. They have bladders, they have rectums, they poop and pee and have sex. So they're just organized differently. The parts are the same, just organized differently. Historically, though, the field of pelvic floor therapy has been gynocentric and very female focused, but we do know that men experience penile pain, scrotal pain, pain with erection, pain with ejaculation, incontinence, urinary, both fecal, sexual dysfunction, and all the things that we're talking about that are important for our overall health and well-being, and very much so impact every aspect of our life because they're vital everyday functions, right? Pooping, peeing, and sex. And when something is just not quite right, that really can envelop your world and start to change how you interact in the world, right? Maybe you go out less, you're less social, you're less active because you're afraid you might have a leakage accident, or you're having this pelvic pain and now dating's become, well, I don't even want to have sex, or how do I tell my partner that I have this pelvic pain issue or this penile issue or erectile dysfunction, whatever it is, often it just weighs very heavily, and then our life starts to transform around this dysfunction. So we know that men often carry the burden of the emotional and physical burden of pelvic floor dysfunction, but everything else that comes with it, emotionally, relationally, social, culturally, etc. So speaking of social, cultural, in pelvic floor therapy, there is a very obvious gap in accessibility to men's pelvic health care. And let me tell you how it creates barriers because men don't know who to turn to, first of all, for these issues. Like they might go to a urologist or they might go to their PCP, but the pelvic floor isn't being talked about, or that these, no offense, guys, like I'm not, y'all are talking about
No,
it.
no, no, no. You're right.
In general,
It is.
there's this gap, right? So it's a gap with the general medical system, but also and providers, but also pelvic health therapists, who a majority of us are female identified. So let's talk about that, because there's a lack of education, there's a lack of knowledge, there's a lack of confidence in working with people who have penises because it's been so female women centric. And that's part of the problem that I myself saw 15 years ago to start to advocate for men in these spaces, because pelvic therapists were not treating men either. And we're still behind. And even in the research, like if you read research on men's pelvic health or pelvic floor, there's not a lot of it out there, to be honest. It's still catching up. The interest is growing. We do have more and more pelvic therapists stepping up to the plate to work with men. And we do actually have male pelvic therapists who work with men and all genders. And I think that's amazing. And I think that's necessary to have options for men. But that's the issue there, the gap in accessibility to pelvic health, the lack of education and community outreach in general about men's pelvic health that creates barriers. And I just want to name a couple of things because this recently came up here in Patreon. Someone mentioned, like, I've been seeing my PCP, my urologist, a GI doctor, everyone, and I'm quoting this stuff here. They're saying sometimes penises hurt, you just have to live with it. or that's a woman's issue. Men don't have those problems by healthcare
Mm.
providers. So, when men's experiences are dismissive, not validated, and basically told we just have to live with it, or quote, man up, no pun intended, with the podcast name here, man up podcast. But I think this is a bigger conversation around many barriers that men might have as far as this misconception around women's health and how that kind of trickles into everything else.
It's
I
so
will.
true. Go
Yeah,
ahead.
I will say when I first came to LA and started practicing, a lot of the physical therapy clinics that I would try to refer to initially, they would tell a lot of my patients, "Sorry, we're kind of like more female focused. We don't accept male patients, or we don't do male pelvic floor." But that has like, I will tell you, whether it's good education by people like yourself, but now like the access has gotten like so much better, and now there are centers like they kind of push and say like we give access to like we focus like even that focus on like guys with men's health issues that need pelvic floor physical therapy. And, so that kind of transitions to the next question. So, how common is it actually for men to have pelvic floor dysfunction? And, why is it so often overlooked and underdiagnosed?
Right. Yeah. So the prevalence of pelvic floor dysfunction in men is actually difficult to pin down, only because it depends on how we're defining and categorizing it from a research perspective, right? For when we're looking at statistics, there isn't a consistent diagnostic language for what umbrella of symptoms or presentations might fall under men's pelvic floor dysfunction, which makes it challenging to really extrapolate accurate prevalence statistics. But that said, in my experience and what I've read through the literature, for example, 1 in every 6 men may experience pelvic floor pain at some point in their lifetime. Or we know that millions of men deal with urinary incontinence and millions of men deal with erectile dysfunction. So the prevalence is there and it's big, okay? The other thing is not many men might be asking for help related to their bladder, bowel, and sexual function concerns. So that also skews the prevalence of, again, the pelvic floor dysfunction data. In my own experience, with Patreon and my community, we have 1,200 members, and many of whom, if not all of them, are there because they have some pelvic and sexual health concerns that they're looking for support for. So in my own little bubble, I know men have questions, they're seeking answers, and they're looking for a compassionate, caring, open-minded, willing to have this conversation, welcoming them and their genitals without shame, embarrassment, or judgment. And then that's really, really important. And as far as why it's overlooked or underdiagnosed, I've been mentioning this a little bit as we were having this conversation, but I think it's likely a mixed factors here. Men generally seek healthcare less for their health related needs. Their concerns are, and when they do seek care, their concerns are often dismissed or minimized. And we do know, in at least the pelvic pain research side of things, that there is a huge mistrust in the medical community with men who have pelvic pain in general. So they don't even think like, what are you going to do for me? You're not going to help me. I've tried that route, etc. And then I've already mentioned the shame and the embarrassment and the stigma that's often tied to issues related to pooping, peeing, and sex, which then further keeps people from speaking up about this in the first place. Especially having someone who has a penis. I feel like there's just there isn't that community conversation and tend and befriend maybe attitude that perhaps is a bit more accessible in women's circles or women's spaces. I don't know. You two have penises. What do you think?
So I think that there's a couple of things, right? I think we already know that often before someone comes to see Kevin or I, who are, obviously specialists in the men's health space, who know how to handle or work up penile pain, testicle pain, pelvic floor dysfunction. Um, the data shows, at least for the testicle pain aspect, these men are seeing probably 2 to 3 providers until they find someone who can actually treat their issue. And to your point, there grows a level of distrust where someone's throwing just antibiotics, or telling them that there's nothing wrong. And it can be incredibly disheartening. And that's part of it. I also think that the prevalence is insanely high. Just to just do the math in my head, so 1 in 6 to 1 in 7 people will suffer with prostate cancer. So you're talking about prostate cancer patients who have been treated for their prostate cancer. You're talking about 50% of men who will have erectile dysfunction. You're talking about another percentage of men, I'm not sure, have premature or delayed ejaculation at some point in their life. So I would argue at some point, 50% of the population, you have BPH, 50% of men have BPH issues. So I would argue, statistically speaking, you're going to have a pelvic health issue at some point in your life. It may not be a permanent one, but you're going to have something that's going to impact your life. And this is really important here because when you put all those things together and understanding that it can take a couple of doctors, unfortunately, to see the right person, this is where communities like yours and actual, advocating for yourself as a patient becomes very important. I think, empowering our patients, educating our patients is why you do what you do, why Kevin and I do what we do. And unfortunately, a lot of the older generation of medicine has not familiarized themselves with pelvic health, especially in the men's health space. But I can tell you very confidently, the generation that includes Kevin and I, um, we are always thinking about the pelvic health of our patients, and we're very readily giving recommendations for pelvic floor PT. But having said that, if you're a patient and you're doing research on your conditions and your physician is not bringing up your concerns, it's okay to advocate for yourself and mention these things. Maybe I have pelvic floor dysfunction. Where can I get assessed by a pelvic floor physical therapist? Because the truth is sometimes they don't know. And also to your point, sometimes there is lacking access in certain communities. And that can also be hard. Kevin lives in LA and said it was hard to get access
Right.
several years ago. I'm in Miami. I'm lucky. I have a great couple of resources down here that, we're creating a pelvic health and penile rehabilitation program for our prostatectomy patients. But, access is definitely part of the issue. And I think physicians who don't have access to something struggle to recommend something that they can't give you a solution for. Kevin, what do you think?
Yeah, no, you're spot on. But I mean, this is why it's so important for awareness and, for, what this episode is. Cause like if you're a guy out there and you've been just blasted on like 6 months of antibiotics, you're kind of like,
Yeah.
when is this ever going to end? Am I just going to stay on antibiotics? Like, these are, you have to advocate for yourself. You understand why, right? In areas that maybe they don't have the access, you are, unfortunately just, those providers will, what else can they kind of do? And so, I do think that's a limiting factor. But hopefully, more access and more access to care and they can go find it. That's kind of the most important thing. Um, I have a question for you actually. Susie, when you do get guys that we refer you over for pelvic floor, like, one of the things that guys always ask me is like, what should I expect? Like guys are super visual. Like for Justin and I, when we do vasectomies, a lot of it's just kind of tell them exactly what's going to
Yeah.
happen the day
Yeah.
of.
Yeah.
Like they want to know like what position am I laying in, right? So for pelvic floor, could you kind of explain to our listeners like what they can kind of expect going into a session?
Yes. Okay. So a pelvic floor exam will include both an external and, if appropriate, an internal muscle assessment. And I have to say this is always a collaborative approach with the patient. So I first spent the first half of that session to just get to know their concerns, the patient, their fears, walking them through exactly what to expect. And that also includes possible spontaneous erections or ejaculation, right? As just purely reflexive, of course, because we are assessing and touching structures that communicate with spinal cord reflexes and your brain. So ongoing consent throughout, and letting them know also that they can defer any part of the exam that they just don't feel comfortable with. So I think that's so important, because there might be this misconception that pelvic floor therapy is a finger in the butt only, and that's the only thing that you can do to help me. And there's again, another barrier potential if we're not giving people options to work with their issues. And it doesn't always have to be that way. Aside from that, let's say we have consent to do everything. What would that look like? The external exam involves a genital pelvic assessment. So here's a little caveat, because I am very aware that not every single pelvic floor therapist feels comfortable or confident assessing genitals, which is a little bit of a pet. It's disheartening, and I kind of get a little like, because it's part of the pelvic floor. And if someone
Absolutely.
has penile pain, if they have glans pain, if they have ejaculation issues, erectile issues, if they have scrotal pain, why are we not assessing tissues associated? There are nerves, dorsal nerves to the penis, musculature, muscle. We need to see and touch and assess. Like, we don't just
100%.
move them out of the
I
way.
do it every time.
Like, don't just tell your patient, move your genitals out of the way. Heaven forbid a testicle pops out. It's like, no, don't be afraid of an erection. Like, it's no big deal. I think that's really important, because there is still often I hear, I got an exam, but it doesn't look like your exams on your, videos. And I'm like, okay. I'm like, well, that it doesn't mean that you can't get better. Don't get me wrong. It doesn't mean that that's good or bad. It just means that practitioner is using what they have in their toolbox and what they feel comfortable with. And that can certainly be expanded upon, especially if you're having penile scrotal issues that really need to be assessed and addressed. And purely just from a, let me validate you as a human being, show me where you hurt perspective. Okay.
100%.
You know what I mean? That's the therapeutic container relationship that is therapy, right? It's like, it's not just what we're doing with our hands. It's, are we hearing them? Are they being seen? Are there issues being addressed? Can you comfortably and confidently just say, show me where it hurts. Let's check it out. That's all part of diffusing the threat. So I'm going to come back from my rant about that. Let's go back to the exam. So I do a genital pelvic floor exam, which is, again, a gentle palpation to assess muscle function. So we assess the tone of the urogenital muscles here, coordination, sensation. I often, if someone has a spinal cord injury, Parkinson's, MS, or any type of neuropathic or neurogenic, like mechanistic pain, then I'll do a full neurological sensory test here. I'll use a pinwheel, for example, or I'll use a brush evoked stimulation. I might use vibration. I'll use a tactile discrimination, meaning can you discern between a soft touch and a firmer touch, temperature. So it just depends on the presentation of symptoms of what tools and I'm going to use to verify or help with my clinical reasoning. So that said, palpation, tone, squeeze, let go, bear down as if you're having a poo, cough, sustained contraction. What does your pelvic floor do when you kind of lift your chin to your chest, or you're doing a Valsalva, like you're holding, you're trying to hold in a sneeze into the crux of your elbow? What does the pelvic floor do? Right. And there are certain things that we observe, right? Does the pelvic floor respond to that pressure? Does it just so lax that it just really descends? What's happening there? Do your symptoms get worse when we increase tension and load through a contraction? So we're just looking for tissue accommodation, load, and tolerance. And then if the patient feels comfortable, then we move on to an internal exam, which is usually a single finger, gloved and lubricated. Sometimes too, if we're dealing with situations like rectal prolapse or general tissue laxity, like a lot of laxity, I might use two, but generally it's one. And they're usually on their side, but they can be in any position that they want to be, honestly, because I want to make this exam comfortable. So I don't really, for me, the position is irrelevant. It's like what's going to make you feel more comfortable in your body. So that could be on your side, that could be on your stomach, that could be in hands and knees. I've done that. It could be on your back. It just, again, depends on what feels comfortable for you. So let's say it's on your side. Have them breathe. Again, we're never pushing past, we're not pushing past resistance or pain. We're just going about this gently. I have them coordinate for relaxation using their breath. I'm very slow. I have them take a deep breath in, I have them contract, relax. And then we assess the deeper pelvic floor muscles there. The obturator internus, which is a hip muscle on the inside. So if someone's got hip pain and that's referring to their hip, then we know that's a referred pain pattern there. So that's the external. Internal, But then, which is another thing that might be unique that I do, and I'm not sure if all therapists do, is a prostate palpation. So I do palpate the prostate. I don't call it a, prostate cancer screening exam or anything, but I will
Right.
tell you, I have found prostate cancer. I've been doing this for 15 years, so my my finger has a keen sense on things of like, this is normal, this is not normal. I have detected prostate cancer. In fact, I had a patient recently, stage 1. Yeah, I think it's important because we as pelvic therapists we can be frontline primary care providers
Yeah.
because we don't need a referral from a doctor in almost all states, I think now. And differential diagnosis and being able to pick up on when to refer out is like a key skill that pelvic therapists, well, they should have, I should say. I won't say that everyone has them, but we definitely learn that in school. Differential diagnosis as it pertains to the pelvis, that's a skill that needs to be acquired and education around that. But we go and feel the prostate again with permission. And if the prostate is there, we are assessing the posterior lobes. And again, if somebody's having referred symptoms to the penis, for example, and I'm pressing on their prostate and that's referring symptoms to their penis, well, that's an area to address. I'm also assessing tissue mobility, flexibility, if they've had radiation treatment or anything like that that might impact structural integrity or mobility. That's important for me to know. If it feels boggy or edematous to touch, that's not within my scope of practice. That might be an infection. I need to refer out for that. But yeah, I think it is important to palpate the prostate. And I have a sense of too, if there's like obstruction, right? So if part of the urethra, the median sulcus, if you're not really feeling it or if it feels really enlarged and someone has lower urinary tract symptoms like urinary hesitancy, pushing to urinate, like I need to know that these are maybe BPO or BPH type symptoms and I need to refer out appropriately. I might also do an ultrasound, a rehabilitative ultrasound that I have in my office. And if someone's complaining of urinary urgency or difficulty emptying their bladder, I might do a, pre and post bladder void to see, like, are you actually retaining fluid? Do we need to send you off to a urology? I'll do a transperineal ultrasound, and then we'll also see like a transperineal ultrasound is really just using a transducer. For those that don't know, it's an ultrasound transducer to underneath the scrotum, and it basically gives us this view, the sagittal or side profile view of the pelvic floor. It's nice for them because they get to see when they contract their muscles, when they relax their muscles, what's happening because it's connecting it with their body if they're bearing down and all these muscles are tensing up. And it's no finger in the butt. So for those that are like, I don't want that, don't, it's like, that's okay, cool. We've got other ways to view your pelvic floor, and I can't assess tone with an ultrasound or I can't assess strength, but I can definitely extrapolate, some information and also help them with pelvic floor training for continence or what have you. So, it's a very helpful tool. So ultrasound might be part of this. Of course, we're assessing for strength, we're assessing for tone, we're assessing for coordination, as I already mentioned. And then we're also doing anal rectal manometry, which is a thing, and EMG, electromyography. So I'm actually in the process of getting my own unit that has anal rectal manometry and EMG so that, again, having objective data is priceless.
Absolutely.
I'm just
Absolutely.
telling you, like,
It's important.
there's no guessing. And the patient gets to see,
Yeah.
oh, wow, like I'm not relaxing my pelvic floor when I'm trying to poop, or my strength or squeeze pressure is really weak. Or if somebody has fecal incontinence, for example, or, they can't expel or push the balloon out because of dyssynergia, right? Pelvic floor dyssynergia, they're contracting rather than relaxing. All these things are super helpful for the clinician, and it makes your exam and your treatment efficient because now you know exactly, like, there's no guessing. There's no guessing. You're like, objective data. I love you. So, anyway, I hope that was helpful in describing kind of
Hey, Justin.
Yeah.
We're both laughing because I'm going to tell you, Susie, like,
what.
I'm like, yo, the way you've assessed and evaluated the pelvis, much more thorough than any urologist.
Yeah,
I know.
I mean, this is
It's amazing. It's so
unbelievable.
good. So
You're like
good.
the pelvis queen. It's unbelievable.
Yeah. So good.
I'm
So
like,
good.
I'm not
Yay!
laughing
That
because
means
we're
a lot from you
absolutely
guys.
blown away. Absolutely blown away.
So
Yeah.
helpful. So thank
I mean,
you.
that is literally, if people are like, what the hell happens? How do they, this is pure science and the most scientific, data driven, most fully assessed way. And if you say that there's no pelvic problem, there's got to be no pelvic problem, right? Like that's the thing, right? But that's important, right? Because the truth is, like, it takes a lot of convincing sometimes for whatever, whether they do have something or they don't have something. And you have literally pulled out every tool in your armament to assess their pelvic health. It's unbelievable. It's unbelievable. That was incredible.
That was incredible. Yeah.
Oh my gosh, thank you so freaking much. Yes, I have refined it over the years. And honestly, like, yeah, you know, when you do this and you get the skill set and the confidence as you go along, it's just it's like you realize, like, no, this is all important. It's all part of what we're talking about. Like, I can't just be like, oh yeah, your pelvic floor muscles are tight. Why? Because and what my finger was able to assess that. And
Right.
like that doesn't necessarily mean that you have pelvic floor dysfunction just because you have greater tone, you know, or increased tone. That like that's not, we know from like a recent systematic review just said that, like, this whole thing about hypertonicity, which is even the incorrect word to use unless you're talking specifically about a neurological population, spinal cord injury, MS, Parkinson's. If there's actual spasticity related to neurological deficit or impairment, then we can use hypertonicity or hypotonicity. But other than that, like, we're talking, we have no we see this person, we have no data of what their pelvic floor was like before. And now we're making assumptions that this, oh, just because I'm feeling this, that must be the cause of your issue. And we're starting to see, like, no, that's really not true. We don't have any conclusive data to support that having greater tone or increased tone of the pelvic floor is causative for pelvic floor pain in specific, as far as this paper goes. But
No, it
anyway,
makes a lot of sense.
yeah, yeah.
I want to just harp on something that you brought up that's really important. I think you casually brought it up. I think it is important that you don't need a referral to see a pelvic floor physical therapist in most states. And I think that's really important. And it goes back to you being an advocate for yourself, because unfortunately, as we've already established, sometimes you're not getting that rec, but maybe you're understanding that maybe this is something that you should do. So can you give us a little more explanation or highlight, like, how, you know, is it sometimes your insurance needs you to have a referral, or is it pretty much like, hey, you can go show up if you're worried about pelvic health, we'll do an assessment and take it from there?
So I think every practice is going to be different about that and what the requirements are. If they're an insurance modeled type practice, they definitely will err on the side of what the insurance wants. And so if the insurance company wants a referral from a physician, then and in order for them to get paid and the patient to have these services paid, they're going to need to jump through some of those hoops. I myself am an out-of-network provider. That doesn't mean no benefits. It just means that I give you a super bill. I'm a cash practice, but you can submit to your insurance for direct reimbursement. And a lot of pelvic therapy private practices are set up in that way as well. So yes, you're certainly welcome to walk in if insurance is not a factor with anything, or even if you didn't want to use your insurance, you're like, oh, I just want to come in for an eval. You're so welcome to do that in the states that allow it. And I do think that all of the states do allow it, at least for the initial eval. There are some states that require an evaluation report or a signature from a physician for ongoing care, but every state is different.
Great. And then the next question is actually a more common question. We've already assessed a lot of men probably have dealt with their pelvic floor dysfunction, but what are the most common symptoms that should make a man think, hey, I might be having a problem with my pelvic floor?
That's such a good question. All right. So, common symptoms that might point to a pelvic floor issue include groin or hip pain, pain between the butt bones, anywhere around the tailbone or the perineum, which is everything in the middle, bothersome tightness or tension in the scrotal, genital, or perineal area. So this could be described as like, my scrotum just feels really tight, my penis is retracted, I feel a golf ball sensation in my rectum, you know, that sort of a presentation. Lower back pain or lower abdominal pain or discomfort. We do know from literature that there is some correlation between lower back pain and pelvic floor dysfunction and vice versa. Pain with sitting, urinary incontinence or post-void dribbling, urinary urgency or frequency, bladder pain, discomfort, or burning without a known infection. Obviously, everything's ruled out. Difficulty emptying the bladder, so straining or pushing to pee. Hesitancy to start urinary flow. Again, that could mean it's more outlet obstructive, essentially pelvic floor related. Fecal incontinence, loss of stool, gas, by surprise. None of that is like normal.
Kevin
Uh,
has that problem.
yeah, let's talk. We'll talk after this.
Off camera.
Constipation, frequent hemorrhoids, straining with bowel movements, pain with receptive anal play or sex. If that's painful, it shouldn't be painful. Pain with erection, pain with, during, or after ejaculation. This lingering pain or burning or stabbing sensation. Again, we're talking about you've been cleared medically, right? There's no red flags. Testicular, scrotal, or penile pain, which we've been talking about as well. So that's a lot. That could happen as far as some symptoms.
But that's really, I know we highlighted right there at the end, like, as long as you've been medically cleared, but I think that's important for listeners, like a lot of the overlap, right? A lot of symptoms that typically you think something medically is going on actually can be caused by pelvic floor dysfunction. And that's so important, right? Again, so that like when Justin and I are kind of like, hey, look, you got to, we're not being dismissive of your symptoms that's happening to you by going like, hey, you need to go see a pelvic floor physical therapist. It's because no, these symptoms could be caused by pelvic floor dysfunction and that we're trying to get you better by going there. I want to jump in now to some men's health diagnoses, that we have or differentials. And I want you, if you could kind of like guide our listeners through like, how the pelvic floor is affecting them. And so one of the most common ones that we will see in our clinics that we send over for pelvic floor is erectile dysfunction.
Okay.
So how can the pelvic floor be impacting erectile dysfunction?
Yes, so important. So, the first thing is I'll just mention that the pelvic floor does play an important role in both erection and ejaculation, and I'll talk about why. But it's just one player, and I know you guys know this. Like when we're talking about erectile dysfunction, the bigger items are vasculogenic, vascular related, diabetes, all those things, right? That is, and also psychogenic. So you have that, psychogenic related ED. And those are like when you're talking underlying root causes. Contributory causes or things that might support erectile function then bring in the pelvic floor. So just having a tight pelvic floor isn't going to cause erectile dysfunction. You know what I mean? Or premature ejaculation. They're contributory causes, but they're not necessarily like the root cause. But if you improve those things, they may also improve the overall function of erection and ejaculation. So the muscles that we're most interested in as far as evaluation and treatment are the muscles that I described earlier on this urogenital triangle. And you can see that these muscles are intimately connected with the erectile tissue. So the bulb of the penis is underneath the scrotum, and then you have the bulbospongiosus muscle around it, and then the ischiocavernosus muscles with the transverse perineal. So these muscles support erectile rigidity and stability and angle of erection. So they increase in tone. So they have to kind of, and this is all involuntary, right? When there's genital arousal or mental arousal, you have a orchestra of events that happen here that tell these muscles to tense up as blood is filling the erectile tissue. They also aid, so their job is to compress, like I'm doing this with my hand of like compressing against the pubic bone. Their role is to compress the erectile tissue to prevent venous backflow or to assist in preventing venous backflow. So they're aiding in compression. And then with ejaculation, involuntarily and rhythmically contract and relax to move fluid out of the penile urethra. Okay, so if you can imagine, if there's low tone here, if there's a neurological issue that's causing these muscles to not function properly, if you are kind of habitually clenching all the time here, it's a muscle. It has a range of motion, and that is going to impact its efficiency. So endurance and speed and power. So
I'll ask you a quick question here because your description was phenomenal, like better than I've ever heard in my life. And I'm putting like all these It's like the meme where I'm seeing all the math go on in my head. You know, men with venous leak, are you saying that men with venous leak, a treatment is potentially pelvic floor therapy?
I would say that's a valid biologically plausible theory. Correct.
That I'm putting in my back pocket. And I'm gonna be sending way more guys with venous leak or suggested venous leak to because that's something I just never thought about. And when you think about the physiology there, I don't know, Kevin, did that like wake up your brain a little bit too?
Yeah, 100%. Absolutely. Like it's yeah, I'm like it absolutely makes sense. It's like almost every guy with ED should be having a male pelvic floor physical therapy eval, right? I
I
think so.
mean, yeah, for
Well,
sure.
and it's not just it's the mechanics of that, but there's more. Wait, there's more. so so sensation is important here too, right? So the dorsal nerve of the penis, it has many different branches. It's on either side. For those that don't know, it's an extension of the pudendal nerve. S2, 3, and 4 keeps your poop and pee off the floor. That's the way I remembered this mnemonic. And it's an important aspect here as far as sensory innervation. So it's important that there is intact sensation, because that is going to impact the communication between muscles and nerves, spinal cord and brain, and everything else in between. So it's important that we assess that, and then we also treat that if that's an issue. And also, again, if the muscles are too tight, too weak, not coordinated, that can also impact sensory signaling in this area that's often very reflexive, but can also be inhibited or dampened based on, again, what other contributing factors might be at play. And certainly, when you have erectile difficulties, and all it takes is one time for that to creep into your mind, and now you're like, is this going to happen this time? And so when we're talking about erectile dysfunction, I, as a sexuality counselor as well, will incorporate the psychological, psychosocial factors of like what might be really damp, but like really inhibiting these reflexes or your body to really connect. So it's a brain body thing that's important, because that might be a bigger piece to what's happening as well. And if we're just, talking about pelvic floor muscles and pelvic floor and being so rudimentary about it, right? Just blaming a muscle, it's way more than that. And so, I think we have to take this with like a very full, wide lens perspective rather than this myopic, like, okay, it's just this is what it is. It's
Yeah.
like, no, we need to coordinate this all together. So that's how I
You're
work.
so damn good. It's fucking crazy. I'm getting
It's
like,
like,
I'm laughing right now. Kevin's laughing. Like, you're like so damn smart. This is so good. And I'm also laughing because we haven't even gotten to half of our questions because it's so good. And we're 100% like going to just add them on for another episode. Like, cause I respect your time and everything. I think we can ask like one more question now. I mean, let's talk
Well, look,
about like,
I want to ask something
yeah,
actually on that note,
yeah.
because we're on the topic of like, look, the most one of the most common guys that Justin and I see, guys who are in their like 20s and 30s who actually got like an STD, and then like they got an STD, and maybe it was some prostatitis that was developed, but it's been cleared, they were appropriately treated, but then they come to me and they say like, doc, that was like 6 months ago. I'm like, I just got like sexual dysfunction, like just massive sexual dysfunction. And I want to say like the way I explain it, and I want you to correct me, Susie, if I've just been completely off and completely wrong. But the way I kind of explain it is like, I think with guys, when we do get these kind of when guys get, potential like infections and stuff like that, that we tend to kind of maybe develop a lot of tension in the pelvic floor area because one, there is hurt going on there, and two, there's a way of like compensating to try to prevent like that hurt from occurring. So I don't know if that's the right way, because I send them to the pelvic floor physical therapist, and those are the best emails I always get. They're like, doc, I feel so much better. I'm going to incorporate pelvic floor moving forward, but a lot of it that gets resolved.
right, absolutely. Well, here's the thing. You're absolutely right. There was a threat, right? There's a threat to them as a person. There's a threat to them in their health, their sexual health. And we know that penis function or sexual health as an identification factor for men is huge, right? Like there's a huge penis centric. Oh my gosh, that is really bad to say together.
It's true though. It's true.
But you know
Huge
what I'm getting at.
penis-centric.
Yeah,
That's
yeah.
the way
It's like
it is.
it's all like there's an identity based around penis function, sexuality, etc. And not just for penis people, but for most of us who have genitals. Anyway, but to your point, you had an STI, there was a scare, let's get real, still, even with the knowledge we know today about like, hey, like 90% of the population has herpes, or, it's like, it's very common, very treatable, etc. It still is going to blanket that person with a little bit of perhaps shame, disgust, embarrassment, fear. How do you have this conversation with a partner if they're not in a long-term relationship and they're just casually dating? There's all that, I think, connected to the context around getting an STI. And then, of course, motor responses are going to be inhibited because it's a damping effect. It's just kind of like, nope. How are you supposed to access your pleasure and your eroticism if you're like, I don't know, is this going to happen again? So I worry about my
Right.
It's
partner.
true.
Like,
Yeah.
I got to make sure I wear like 3 condoms at the same time. Please don't. That's definitely not advised. One, otherwise you're at risk of getting an STI because it might break. Anyway, all of
I
that.
think 5 is the magic number, by the
Is
way.
it the
5
magic
is good.
number?
5 is
Okay.
good. Do not listen to that. That's not good.
But you know what I'm getting at, right? It's like there's so much of like, there's an anxiety. Okay. There might be an underlying nervousness, protecting of their partner, there's disclosure involved, all of those things, if that's part of the conversation, depending on the type of STI. But yeah. And if it's like a prostatitis situation, well, now you've got, it's immune mediated responses as well. You've got their immune system kind of high alert. You have all these cellular mechanisms that are protecting you. They're protecting you. And until you have data through experience, so whether that's pelvic floor exercise, masturbation, partnered experiences, until you have new data to supersede the old data of danger, threat, bad, wrong, whatever, it will still be inhibitory. So we do need new data to support confidence, reassurance, you're safe, the threat abated. And that's when things kind of start to come back online. But that's through neuromuscular training, touch practices, reassurance by clinicians, educating people, all those things to help rebuild, confidence and reassurance in their body.
Damn.
Yeah.
That was good. That was good.
You're so good at explaining things. So good.
You're so good at explaining things. Like, you're amazing at explaining stuff.
Oh, you guys, I'm blushing. That means a lot coming from 2-year-olds.
No, I mean, you really should just be on a world tour for
Yeah.
everyone. Honestly, I'm not even kidding. Be on a world tour. You should be you've never come to SMSNA before, like, or AUA for any of those. Like, you should be a guest speaker.
No, I haven't.
1,000%.
Oh, 100%.
Oh
Absolutely.
my God. You're like,
Yeah.
it's crazy. But, and we'll figure that out. I'll try and get you out there. But anyway, so like, we're running out of time. You're going to come back on.
Yeah.
Because we have literally a whole page of additional questions that we haven't even touched.
We've only scratched the surface.
We've only scratched this. We're only just our finger is just starting to do the internal exam. We've done the external exam. Now we need to do the internal exam for our second part. Okay. But so we'll definitely have you back. We're going to take note of what we talked about. But for our listeners for now, tell us where they can find you, because everyone should be listening to you. Everyone should be on your Patreon. Everyone should be listening to your YouTube. Tell our listeners where they can find you.
Well, thank you for the shameless plug, but you just did such a wonderful job of telling people where I'm at. Thank you very much. Yeah, so first of all, thank you so much for the wonderful compliments, and I am truly humbled. Like, you probably see I'm probably red. I'm blushing. I'm very humbled because your feedback means a lot. So I appreciate that. I have a website, susieg.com. So that's my clinical practice. You can learn more about me and our interdisciplinary team there. I'm on YouTube, as you said, at Dr. Susie Gronski. I'm sure if you type in my name, you'll see me on the interwebs, and Patreon. Yeah, Patreon at Dr. Susie G. Patreon.com/Dr. Susie G. DRSUSIE. I'm also on Instagram and TikTok, but mostly just for sharing, for more of the community engagement and one-to-one interaction with myself and the community. It's definitely Patreon.
Okay, cool. What's your socials though?
Instagram is Dr.Susieg, and TikTok is DrSusieg. Dr. Susie G.
Make them the same. You got to fix that. They got to be the same.
I tried. Somebody has that Dr.
What?
Yes, on Instagram. I tried. I tried, and I even reached out to this person because they have like no post. I'm like,
Just
well,
give it to me.
yeah, I'm like, can we just make a swap here? It's been a while. Maybe I should revisit that.
Revisit
it. Okay.
But listen, this was unbelievable. This is such an important topic. We're having you come back. We got so many more questions to ask. So thanks to our listeners. Download, subscribe, give us a review. This is on YouTube. We have amazing, Susie has like a whole model here that would be really helpful for you to see and learn through. So make sure you subscribe to our YouTube. Thanks as always. Give us a review for Kevin, Justin, Susie. Until next time, have a good one.